Good morning, good afternoon, good evening, wherever you are in the world, and thank you for joining us today. I'm Emma Rule, your moderator for today's event, and a senior researcher here at the United Nations University's International Institute for Global Health. Based in Kuala Lumpur, Malaysia, IIGH is one of 13 institutes that make up the UNU and is the UN's designated think tank on global health. Our work centres around three pillars: the generation of policy-relevant research and analyses, particularly with respect to gender and health, the translation of evidence into policy, and the strengthening of capacity for local decision-making. In early 2019, IIGH embarked on a journey to understand the decolonisation agenda within global health, what that might mean for us as an institution, and what we could contribute to the broader discussions and calls for change. It started with a very necessary reflexive examination of our positionality, both as a UN institution based in the so-called Global South and as individuals. We also conducted an analysis of the decolonising global health literature and had many thought-provoking conversations with people that generously shared their time and inputs as we sought to better understand the topics under discussion and to identify individuals and networks agitating for change. I've been fortunate to be a part of this endeavour since its inception, and this milestone would not have been possible without the rich contribution of colleagues, both past and present, to the development of our thinking. It's been a long process, both consultative and collaborative, to get us to where we are today. We've seen that there is no single movement to decolonise global health, rather a diverse plurality of initiatives reflective of the complex and contextual nuances of reimagining global health. A common point of unity, however, has been a clear push for the need to move from theory to action and to hold ourselves and each other accountable for making the change that we want to see. So with that, I have the pleasure of introducing our four panellists for today, who will talk about the ways in which colonialism and coloniality manifest in their global health work, and really representing views and stakeholders from across the global health ecosystem, and some of the ways that they've sought to counter these forces. David McCoy is the research lead for IIGH's evidence to policy work, under whose leadership the programme of work launching today sits. Prior to IIGH, David was Professor of Global Health at Queen Mary's University, London, and has previously worked within civil society, including as a member of the Steering Council of the People's Health Movement for 10 years, and in the public sector, including during the immediate post-apartheid transformations of South Africa's healthcare system. David will be followed by Sabina Rashid, the Dean of BRAC's James P. Grant School of Public Health in Bangladesh, where she is also the director of the Centre of Excellence for Gender, Sexual and Reproductive Health and Rights. Highly respected both at home and in international fora, Sabina sits on the advisory panels for several organisations spanning health systems and policy and human and reproductive rights, and is a member of the National Working Group Bangladesh Health Watch, a multi-stakeholder civil society advocacy and monitoring network dedicated to improving the health system in Bangladesh. Next, we'll continue to move west over to Uganda. Danny Gotto is the founder and current executive director of Innovations for Development, a development practitioner with over 20 years of hands-on experience designing and implementing both medical and community health initiatives. Danny is a vocal champion of the right to health in sub-Saharan Africa. Our final presentation today will be given by Anna Marriott, the Health Policy Manager for Oxfam and the co-policy lead for the People's Vaccine Alliance. Anna has led Oxfam's policy and influencing work on healthcare for the last 15 years and has published several papers on health financing and healthcare delivery, including on the risks of increased commercialization. During the pandemic, she has played a leading role in making the case for COVID-19 vaccines as global public goods. After the presentations, we'll open the floor for Q&A. We are really grateful to see the fantastic audience that has joined us today. And we know that with the number of people joining us across YouTube, Zoom, and Twitter, it's just not going to be possible to involve everybody in the way that we might like. But please be assured, today is just the beginning of this next step in our journey. Over the coming months, we will continue this conversation, both online and in person, and we're actively seeking collaborators to join us and to continue to work with us. With that, let me just give you a few housekeeping reminders. We want this to be as lively and engaging as possible, so please do use the chat boxes or comment sections on whichever platform you're joining us from. Add your name, let us know where you're from, and also add any questions that you have there. We'll be using those to put to our panelists in the second half of today's session. Please also feel free to share your thoughts and comments and do express your thoughts. Let's move over to Danny. Thank you very much.
Yes, hello everyone. First of all, I'm very glad to be here, and I congratulate the Institute for this milestone of setting up, a decolonizing global health discourse. This has come handy at the right time when this part of the world is grappling with some of the key challenges that David has well elaborated. I want to begin with my journey in the global health. Of course, I'm a public health physician. I started as a medical practitioner. I've worked in all sorts of settings, both public facilities run by the state. I've worked for NGOs. I've worked for programs funded by PEPFAR, USAID, DFID, and to name it. But one thing that kept coming through is the story of Africa. Of course, this story has been told and retold. But when we look at the numbers, Africa is 17% of the global population, and 28% of the global disease burden is in Africa. We have 75% of the poor people across the world are in Africa. And estimates are showing by 2030, 90 or 95% of all poor people will be in this part of the world I call home. The question is that why, for so many years of, a lot of people celebrating how they are working in Africa, we've remained the poorest. Not because we lack resources, we are the most resourced continent. We have 30% of the fresh water. We have 60% of the arable land in the world. But we contribute nearly 50% of the numbers on hunger. So the question that used to come into my mind as a public health student and as a physician is, how come that the rest of the world has contained malaria? The rest of the world has figured out with diarrheal diseases. The rest of the world has addressed some of the challenges that we're having, but we are not. Then much later, I came in contact with NGOs. I saw firsthand how NGOs designed programs. Most of the time, interventions were designed outside Africa, launched into Africa, and numbers are picked from communities and celebrations are done, but nothing fundamental is changing. It is estimated that for the last 30, 40 years, Africa has received about $2 to $3 trillion in development assistance. But when you look, nothing is. What is happening? Then somewhere, somehow, I got to learn about the discourse of coloniality and decolonization. And I dug deeper into understanding how was power playing, what role was Africa playing in contributing to the problems, what externalities were we suffering from that were making us vulnerable to this extent. Then I discovered that the game is not for us. The system was never designed for us to break out. We were subjugated, as like David shared, and we continue to be subjugated. We don't grow what we eat. We don't produce what we use. Everything that we produce goes out. We are paid peanuts. Our economies cannot sustain incomes that can meet the health needs of our people. So aid becomes the only alternative if we don't fight back. That comes in to solve the problem. So moving on, I much later now, saw the structured adjustment programs, how they defunded health, deindustrialized much of our industries, because we were being lectured to by those with power and money that governments have no business running business. So the private sector should lead and the private sector should invest. Africa missed out. We didn't see the private sector. The small little private sector was incapacitated. The one we had internally was incapacitated in my countries. A lot of factories that we had that were, financed by the state were defunded. We've seen a net migration of health workers to the developed north. They have not recognized this migration, and by the time the HIV epidemic came in 2000, at the peak of the epidemic, our health system was crumbling. So we had to reinvent ourselves by designing community health worker programs, volunteers coming to reach out to communities and supporting to give some bit of response. NGOs came, they pondered on the idea, disorganized it through sometimes useless money, and they left. Others, new ones came, they formed a silo approach, disease-based programs. They cherry-pick diseases of interest to them. Now, a wider mass of people were left out. I give you an example. I've worked in the HIV sector for the last maybe 15 years, I should say. 90% of the HIV funding in my country is by the United States government, primarily PEPFAR. That money, 90% of it is going through international NGOs. They are the ones who design the interventions, and then, from the American capitals or cities, they bring them to Africa to implement. They employ Africans, give a particular rate of salaries. Because of the interests and the opportunities that come with NGOs, we've seen a migration of health workers from the health sector to work for NGOs. Remember, we have a small pool of human resource. Most of them have migrated out. Others are seeking and struggling to work for NGOs. As you know, much of the NGO business, the model is 5 years, invest, move out. Then you see health workers moving from one project of nutrition to HIV, to maternal health, and there's no consistency. There is no sustainability. So that confusion has created the continuing disease burden. Then we saw international mechanisms like Gavi, like Global Fund coming in. When you read their literature, they are saying we're building Africa's health systems. But surprisingly, which came out in the period of COVID, Africa only produces 1% of the vaccines that it uses. For heaven's sake, you've been in Africa for 10, 15, 20 years, and the people you're claiming to support do not produce the vaccines. Whose vaccines are you promoting in Africa? How come that Africa cannot produce its own vaccines? Is it the lack of institutions? Is it the lack of our technical know-how? What role have you played in building the technical know-how so that we know that you've tried? Zero. Much of the relationship is, of course, extractive. We've seen their investments promoting their technologies and products, introducing them to our people and locking them. The classic example is the COVID time. When we were crying out 2 years back, the rest of the world were getting jabbed. We didn't see vaccines. Countries like Canada, the United States, were, having stockpiles of vaccines. None was given to us. When we started making noise, the only thing they would think about is donations. Now, this is the thing that donation did. We had created networks and relations with, for instance, China. China was producing vaccines. Now, when they heard that we're picking vaccines from China, they introduced theirs. They gave them free. Now, when you introduce free vaccines good enough, you give for the first time free, you lock the population. Now, once you lock the population, they pick interest in that, then the alternative is that our governments need now to go back to the companies to buy. Why? Because they cannot accept us to have the intellectual property rights to reproduce the vaccines. They still want us to do the same and same. So with that, I think we need to get back to the drawing board. We need to push back. We need to localize our efforts and our health. We need to deconstruct the systems and structures that have made us vulnerable to most of these global health issues. So I thank you. I think I stop there for now.
Thank you very much, Danny, for that a really striking set of figures. And a reminder that even as we think about global health, that really there are so many different aspects of society in our day-to-day lives that touch on health and health systems. And your comment about systems that were never designed for us has really struck me, and I think is one that we will come back to along with the vaccines conversation in the Q&A. And so for now, I'd like to pass to our final presenter for this